Good afternoon, everyone. I am Dr. Mostafa Adam from Egypt National Heart Institute. So our patient is 68, male patient, hypertensive, diabetic, complaining of chest pain, dyspnea. Echo shows ejection fraction 43%, regional wall motion in anterior anterolateral wall and septal wall hypokinesia. Dobutamine echo shows viable LED. So this is the coronary angio. We have a proximal total LED, heavily calcified. And this is the injection from the RCA. So what's your strategy? So this is the algorithm we work with. We have the assessment. This is the proximal cap is a blunt stump. The length is more than 20 millimeter. Distal cap, good caliber, collaterals from epicardial collaterals. So our plan was between antegrade wire excretion, ADR, or retrograde. So this is the dual injection. We start antegrade using Crossair Pro and Fielder XT wire. Then this is a contralateral injection. I think we are not in the LED. So we return back and shift for guy third. Finally, I think we catch the true track. So, does passing the wire is the end? No. We have two major problems there. Heavy calcification at the proximal LED. Second, big diagonal at the distal cap. So this is the rule of imaging modality, especially the IVUS. The IVUS image give us a data that the vessel diameter is 4 millimeter proximally and 3.5 at the mid. And the calcification shows the calcium arc from mid to proximal 270 degree. Multiple runs of rotablator to prepare this lesion, followed by multiple lesion preparation using regular balloons. This is some dissections. And this is the LED dissected, and we lost the diagonal branch. So, plan there, one stent, provisional stent and bailout tab, or two stent strategy from the start, mini crush or decay crush. So we start with mini crush technique. Here we are crossing to the diagonal branch, preparing it, then the section increased in the LED. So, continue our strategy or fix LED or fix diagonal. So, what do you think? Stable. Okay, we stented the diagonal branch using 33 millimeter stent, crushing it, then stenting LED from distal to proximal, 348 millimeter stent. Overlapped proximally by 438 millimeter stent. LED is okay, but what about the diagonal branch? We lost it again. So we crossed to the diagonal branch using Fielder wire. And this is kissing, but, and this is the final scene. Is this okay? Some intracoronary adrenaline and flushes, and we restored it. This is the final scene. Is this okay? we have a distal wire perforation in the diagonal, and the patient starts to collapse. This is the algorithm how to manage coronary perforation. We have prolonged balloon inflation, IV fluid, precardiosynthesis, or surgical notification. So we have, if we have large vessel or distal vessel perforations, we have options: embolization or covered stent. This is the options: balloon inflation, embolization, fat or coil, and we don't have coil at our cath lab, or covered stent or surgery. This is the comparison between fat and coil embolization. Here is the source. So we start with fat embolization. This is fat embolization. We take a fat from the groin region. This is the fat, and injecting it through the microcatheter. This is the injection. And this is the final thing. This is a follow-up echo. So our take-home message: high score CTO, calcification, bifurcation, perforation are the most tough scenarios in coronary intervention, but good planning can save your procedure. Always respect calcification. Rotablator can help you. IVUS can help you on estimation the actual size of the vessel and the calcium arc. Don't lose a sizable diagonal branch supplying large area of myocardium, and be ready for bifurcation. Regarding side branch, DCB may solve it. Always notice the distal wire tip, and if distal wire perforation occurred, coil and fat can solve it. Thank you.